Yeah. So it's now 12:02, and I think we can begin. So I want to welcome everybody to April Cardiology Grand Rounds. Make sure that everybody has a wonderful holiday as well, whichever holiday you're celebrating. Hope that it's a meaningful one. And glad you were able to join us for Cardiology Grand Rounds. You're in a treat for today because we have Dr. Jeffrey Lee is going to talk to us about coronary CTA. We don't really hear much about this in our lectures and grand rounds, so I think it's an opportunity for us to grow and learn. Dr. Lee is a graduate of Occidental College in Los Angeles, California, with a Bachelor of Arts degree, followed by medical school at Western University of the Health Science in Pomona, California, where he got the DO degree. Then he did his internal medicine residency at Rowan School of Osteopathic Medicine here in New Jersey, and he was selected as chief resident there. And he went on to do his cardiology fellowship at Deborah Heart and Lung Institute in New Jersey as well, Browns Mills, New Jersey. We were able to recruit him from the West Coast back to the East Coast, and he joined us at Cooper, as we all know, a little over a year and a half ago. Dr. Lee is board certified in internal medicine, cardiovascular disease, and also, I'm told by Dr. Heinz that she can't hear. Can people hear me? Hello?
I can hear you.
We can hear you.
Others online can hear? Okay.
Yeah.
Kathleen might need to check her connection. Anyway, Dr. Lee is board certified in medicine and cardiology, and also cardiovascular computed tomography. And he has special interest in that. So we welcome Dr. Lee to speak to us today. This is Cardiology Grand Round, which is a CME program. Dr. Lee has nothing to disclose relative to today's program. At the end, there is a review sheet that you should fill out as well and return it to Tina Morfa for our CME. So without further ado, Dr. Lee, I'll turn it over to you.
Thank you very much for the introduction, Dr. Weinstock, and good afternoon, everyone. For the purpose of this talk, I'll be talking primarily on coronary CT angiography. There are other aspects of cardiac CT that deserves its own presentation, but there's a lot to cover, and I'm excited to give this talk. So I'll be going over the past, present, and future of coronary CT angiography. I have no disclosures. As an outline, I'll be going over the history of electron beam CT, multi-detector CT. I'll be going over the background of assessment of cardiovascular risk, and I'll be going over coronary artery calcium, and I'll be going over key clinical trials. There are a lot of trials out there, and I'm just trying to narrow it down, but even just typing in Scholar Google, you get 480,000 results, showing that there is a lot of interest in this field of coronary artery calcification and identification of this as well. I'll be going over asymptomatic versus symptomatic, going over guideline updates. And as for coronary CT angiography, this itself has many resources to choose from, of up to 46,000. I'll be going over major clinical trials. I try to cherry pick the ones I felt that are most relevant to the guidelines, and also be talking briefly about the CT-FFR and the future directions. So the history of CT originally started, and the idea started in 1975 by the Biodynamics Research Laboratory, and it came up with called a dynamic spatial reconstructor. And the original design was quite large. It was 2 floors with gantry and imaging chain. It was quite impressive that they were able to achieve a spatial resolution of 1 millimeter, and keeping in mind that current CT scans about 0.5 millimeters. The image reconstruction were cumbersome and would take several weeks to complete, and since it was difficult to maintain and it was quite cumbersome to use, it was eventually decommissioned in 2002, which then led to the EBCT, or electron beam CT. It was discovered and invented by Dr. Boyd at Stanford in the 1980s. And when comparing the previous CT scan to the EBCT, there were no mechanical moving parts with this imaging modality. And the photon rays would go through a tube, and when the patient laying supine, the patient would then have the X-ray photons go through the patient from the posterior. And because there's no moving parts, the temporal resolution was improved. And the whole thought of EBCT actually came about since at that time, echocardiography was improving technology. So they were looking for other modalities that can give three-dimensional structures, and that's why EBCT really came to light. One of the things I will talk about is that it was able to identify coronary artery calcification. I'll go over the next few slides. That there was relatively few units were installed due to the high price and low production volume. And since the EBCT was primarily for the heart, and it was very limited in its clinical use, which then led to the coronary CT and multi-detector CT was initially invented in 1989, and at that time was a single slide CT. And over time, there was an improvement in the scanner size, and now 64 slide CTs were made in 1995. And keeping in mind that 64 slide CT is the bare minimum slices that's required for both cardiac CT as well. And over time, there was an improvement in temporal resolution and the faster Ganser rotation time as well. And then there was an improvement in reconstruction techniques. And with the increase in slice thickness, the higher the slices that you have, the more coverage of the heart you're able to obtain. And they actually have CT scanners up to 640 slices. And with that, there was now dual source CT where you have X-ray tubes that are 90 degrees from each other. Therefore, 90-degree rotation will be enough to cover the heart. So I just want to touch briefly on Dr. Arthur Agatston. You may know him both from the Agatston score and I guess more recently the inventor or the writer of the South Beach diet. So initially the Agatston score was quantified with electron beam CT. And at that time, they elected to use 3 millimeter slice thickness and greater than 130 Hounslow units. And he felt at that time that it was the best compromise of temporal and spatial resolution. And even though the discovery of the Agatston score, they introduced this to the Radiological Science Society of North America in 1988. But at that time, it led to underwhelming response, and there was skepticism regarding this score. It wasn't until March 1990 when Jack published the data on calcium score and clinical results is when it started leading to increased worldwide adoption. And just touching briefly about calcium score is a CT scan, no contrast is needed, and again is based on axial slice thickness of 3 millimeters, which was the original method by Agatston in the past. It requires about 1 millisievert of radiation, or about 3 months of average radiation for the average U.S. resident. And the Agatston method is when they have a weighted sum of lesions with a density above 130 Hounslow unit, and you multiply the area of calcium by a factor related to maximum plaque attenuation. For instance, in this case, the maximum Hounslow unit is 215. Therefore, it's a factor of 2. Multiply 2 times 2, so therefore the calcium score is 4. Before going more into details regarding the calcium score, I just want to just touch briefly upon the assessment of cardiovascular risk. And as providers, we have many consultations regarding risk scores and primary prevention methods to treat our patients. And then the most recent guidelines, they recommend what's called a pooled cohort equation, or as you know, the ASCVD risk score over 10 years. And if you look at the pooled cohort equation, they primarily look at the ages of 40 to 75 years of age. And although you could use a lifetime risk score for those who are under 40, you can't really calculate the 10-year risk score. And whenever you try to calculate pooled cohort equation and you place in the patient's risk factors, including diabetes, hypertension, hyperlipidemia, one of the factors is ethnicity. And as you know, if you choose the 3 options are Caucasian, African American, and other. And turns out when you choose other, it's actually the same risk score as Caucasians. And as you know, there are different risk categories and risk scores for other ethnicities. And so there are times when you may underestimate a person's risk score if you choose the other on the pooled cohort equation. And for instance, in South Asian and Southeast Asians, choosing other would underestimate their risk score. as opposed to for a Latino or East Asian population, it would actually overestimate their risk score. Not only does the pooled-core equation focus on certain risk categories or for risk stratification, they also don't take into account a family history of premature CAD, nor does it take into account of history of chronic inflammatory diseases such as rheumatoid arthritis. Now, you may recognize the diagram below, but I just want to demonstrate about the pathology of coronary artery disease. And so in the early stages, you start developing fatty streaks, which then lead to increased inflammation. And with the inflammation, the body starts upregulating osteoblasts and start developing more calcification in the coronary arteries. And it's at this time when, although they're able to develop coronary artery calcification, at this time, there's not enough stenosis to really, for patients to develop any anginal symptoms. And just keep in mind that the calcification is an estimate of total coronary plaque burden. And this gives us an opportunity to treat patients at an earlier stage in their coronary artery disease process in order to make and recommend lifestyle changes and even changes in the pharmacotherapy to hopefully prevent a future cardiovascular event. So just as a case, I want to go over this case of as a 59-year-old Chinese female who's asymptomatic. She has a history of hypothyroidism and hyperlipidemia, not on therapy, who presents to discuss her family history of premature CAD, given her father had an MI age 41. She follows a strict diet of vegan, exercises 5 times per week, no other risk factors. And her fasting labs are quite elevated. Her total cholesterol is 248, TG was 61, HDL 97, her LDL was 141. She declined other tests such as lipoprotein A and apolipoprotein B and even high sensitivity CRP. So we discussed the pooled cohort equation and calculated her overall 10-year risk score, and it came out to 2.2%. And as we discussed earlier, the risk score may overestimate risk in East Asian patients. So what should we do next? So as you can imagine, given that this talks about cardiac CT, you know what we did next. So the calcium score there are many trials of the calcium score, and I try to just cherry pick the ones I felt that is the most important. So Budoff and colleagues in 2007 had a trial where they looked at 25,000 patients, and of these patients, 11,000 had 0 coronary artery calcium score. And at a 12-year follow-up, they noted that the survival rate was about 99.4%. It's quite impressive, as opposed to those with a calcium score of greater than 1,000, which resulted in 965 patients. The 12-year survival rate was much lower at approximately 77%. Now, if you look at the diagram to the right, you notice that the increase in calcification of the coronary artery led to worse outcome over time. And in this case, it was over 5 years. You know that those with a coronary calcium score of over 1,000 was about 82%, and at 12 years was, as we mentioned before, 77%. Sarwar and colleagues did a meta-analysis, and they actually included Budoff's trial in this as well. And they compiled about 13 studies, 65,000 patients, and of these patients, about 26,000 did not have a coronary calcium score. And it was impressive that only 0.56% had a cardiovascular event at 51 months. And it was interesting when you dive into the data that 30 of these events were due to hemorrhagic stroke. So it's unclear if the coronary calcification actually correlated to these events. However, also in one of the studies, which had majority of events, in the study, they actually used slice thickness of 6 millimeters instead of 3 millimeters. So there's a question that some of the coronary calcification may have been missed, leading to worsening events. And after the meta-analysis in 2009, Blaha and colleagues actually had another follow-up study about 44,000 patients, middle-aged, low to intermediate risk without known CAD. And they noted that those with a calcium score of 0 led to about less than 1% chance over 10 years of having an event over 10 years. And so the whole thought of power of zero is a powerful and a positive prognostic factor. and can be applied to certain patient populations. I just want to follow with the MESA study. You may have heard of it. It's called a multi-ethnic study of atherosclerosis. It's about 6,000 patients between the ages of 45 to 84 years of age, and the average age was 62 years. And it was primarily based in U.S. communities. It was, I believe, it was Houston and Seattle, so it was quite varied in terms of location. And they sorted patients by age, gender, race, ethnicity. And as opposed to the pooled cohort equation, they included Hispanics and Chinese as well. And they primarily looked at asymptomatic patients and who are free of cardiovascular disease. And most importantly, they actually excluded those who are diabetic, since diabetics are more likely to develop coronary calcification at an earlier age. And so if you ever look at the website, you'll see, a calculator that would include the age, gender, their ethnicity, and you can, if they undergo a calcium score, you can type in their score, which will then calculate their overall percentage when compared to those who fit the same demographics. Now, there's also included in the MESA trial where it's interestingly that females between the age of 65 to 74 years of age, about half do not have any coronary artery calcification, and as a comparison to males, about 25% did not have coronary calcification between the age of 65 to 74 years of age. This diagram will actually be important in a future slide during this presentation. So, and looking at the guidelines of 2018 blood cholesterol guidelines and the 2019 primary prevention guidelines, they recommended that those are the calcium, that you can perform a calcium score for those who are between the ages of 40 to 75 years of age and who have an ASCVD risk score of 5 to 20%. And they feel for this population, you can reclassify the patients and can potentially see who will potentially benefit from statin use. And you can withhold statins if coronary artery calcium is 0, with the exceptions of those who are cigarette smokers, diabetics, strong family history of ASCVD, or chronic inflammatory conditions, a class 2A recommendation. And as a follow-up, there was also a coronary artery calcium score consortium who were looking at those who were younger than the ages of 40. And it was quite a large study of about 22,000 asymptomatic patients. And these patients actually, majority had a risk factors for cardiovascular disease, including hypertension, hyperlipidemia, current smoker, and they actually included what's called family history of the CHD. And they didn't break it down into premature CAD, they just included family history in general. And what they noted is that in this age group, and especially to those with a calcium score greater than 100, they had over 10 times risk for CHD mortality. And so the calcium score consortium questioned the value in pursuing those who are between the ages of 30 to 49, especially with a family history of premature CAD. And so in this case, although the 2018 blood cholesterol guidelines and 2019 primary prevention guidelines leaned away to those who are above the age of 40, we should consider to use at a younger age depending on their overall risk score. So there's a patient population of calcium score of 1 to 100 that we can potentially miss, treating them at an earlier age and helping with either lifestyle modification or pharmacotherapy. So what should we do in terms of management? So the calcium score of 1 to 99 favors statin therapy, especially in those above the age of 55 years of age. And you can consider the use of aspirin with a calcium score of 1 to 100 if you anticipate the benefit is greater than the risk. And just to let you know that number needs to harm was about 442 for one major bleed over 5 years. And if you look to the right, although for instance, the calcium score of 1 to 100, if you feel that the Framingham risk score is greater than 10%, then the use of aspirin therapy can be considered. And as you know, there was a recent USPTF guidelines that really shed the light about if aspirin is beneficial, but if you have the identification of subclinical coronary artery disease, then after a provider and patient discussion, aspirin should be considered. For those who have a calcium score greater than 100 and or they fulfill greater than 75th percentile based on MESA score, aspirin stent should be considered. And the thought in terms of seeing is believing, and what they noted is that those who had an elevated coronary calcium score, they are more likely to adhere to lifestyle modifications and adhere to medical therapy. And what they did was they followed patients from calcium score of 0 to the calcium score of 1,000, and they noted that the increase the coronary calcium score, the more likelihood the patient was going to continue his regimen. So going back to the 59-year-old Chinese female, so a coronary artery calcium score was performed, and she had a coronary artery calcium score of 47 involving her LAD. And as we went to the MESA calculator, we put in her age, gender, ethnicity, and she came out to 84th percentile. So if we just rely solely on the pooled cohort equation, there may be a population that we may miss treating for earlier medical therapy, or missing a point where we can make a difference in terms of overall cardiovascular risk. And so let's switching gears into symptomatic patients. So the coronary artery calcium score was thought of in previous trials for those who were having symptoms. And then in 2012, 13, 15, and 19, the suggestion of coronary calcification for those who were having chest pain was not well received, and it received a 2B or even a class 3 recommendation. So let's go over some data. So the study was in Houston, and it's about 5,000 patients who were symptomatic without known CAD at low to intermediate risk for ACS and a TIMI score of equal to or less than 2. And those with a TIMI score of 3 and above, they actually went on to nuclear stress tests and even invasive coronary angiography. But in this study, those with a TIMI score of equal to or less than 2, they underwent a coronary artery calcium score and a CTA. And of the 5,000 patients, almost 3,000 had a calcium score of 0. And when undergoing the CT angio, they noted that of the 2,900 patients, 21 actually had obstructive coronary disease, which equates to about 0.7%. And what they realized that in those who are low to intermediate risk for ACS, who did not have any concerning EKG findings or normal troponin levels, they noted that the negative predictive value for greater than 70% stenosis was 99.6%, so very low. This is followed up with another study with 1,700 symptomatic patients with no known CAD with stable angina. They excluded those who had high-risk features or such as CAD and MI. And of the 1,700 patients, 900 had a coronary artery calcium of 0. And of these patients, about 2% had obstructive coronary disease, and therefore like lipid-rich plaque. And they just noted that it was a 98.1% negative predictive value for excluding obstructive CAD if they had a calcium score of 0. Now, this is an older trial in 2008, very small compared to the previous ones, but in this trial, they looked at high-risk patients, so 40 symptomatic presenting with acute coronary syndrome, 25% of which had a history of previous PCI and previous MI. And these patients underwent a coronary calcium score, a CT scan, and then underwent an invasive coronary angiography. And of the 40 patients, I know it's a smaller study, but of the 40 patients, 13 patients had a calcium score of 0, and 5 of which had significant stenosis. So 13 patients had lipid-rich plaque without any evidence of coronary calcification. And one of the examples they provided was, you can see here that there is a total occlusion of the mid-RCA, and there's no coronary calcification identified within this lesion. And you can notice that in the invasive coronary angiography, it correlated to this finding as well. So given these findings in high-risk patients, coronary artery calcium score is less reliable. And even though a calcium score is 0 for high-risk patients, you cannot exclude the presence of atherosclerosis. So how was this reflected on the 2021 chest pain guidelines? So in the chest pain guidelines, you note that they gave this pyramid structure. And if you note that those who were asymptomatic no testing is required. Simple, easy. For those who are at low risk, you can even defer testing, or you can consider EKG or a coronary calcium score. And so in low-risk patients without no known CAD with stable chest pain, calcium score is a reasonable option to identify patients with low likelihood of obstructive CAD. Class 2 recommendation. And in intermediate higher risk patients without known CAD with stable chest pain, you can consider calcium score as an add-on testing if the previous results are positive or inconclusive. And one of the examples would be that you have a mildly abnormal functional stress test, then you can consider using a coronary calcium score as an adjunct to optimize medical therapy. And one other iteration from the 2021 chest pain guidelines, they included what's called a cutoff of pretest probability of greater than 15%. And they actually provided this diagram within the 2021 chest pain guidelines. And it's actually a modification from the 2019 ESC pretest probability article, which they actually they cross-reference with the confirmed trial in Denmark registry. Well, in the original 2019 ESC pretest probability paper, they actually broke it up into typical, atypical, and dyspnea. And as you know, in the 2021 chest pain guidelines, they recommended to, I guess, steer away from the term of typical and atypical angina. And therefore, in the 2021 guidelines, they just said chest pain and lumped it together. Now, how does coronary calcium score really, I guess, how is it incorporated with this as pretest probability? Well, if you have a patient who had a coronary artery calcium score of 1 and above, this automatically places the patient of greater than 15%, thus suggesting that the patient should undergo further ischemic evaluation. And collectively, we will look at this CT scan and notice that there's a dense calcification involving the LAD. And I would say in this case, one would argue that the patient should either undergo invasive coronary angiography or even a a nuclear stress test. So I know all you have can recognize this orange donut in the nuke lab. And I hope that collectively that we would all say, just by looking at this stress test, that this is negative and non-ischemic. This finding would also be seen in a patient who has no coronary disease whatsoever, no plaque, no calcification, in a patient who has 1 to 25% calcific plaque involving the proximal LAD, or in a patient who has a tubular lipid-rich plaque with positive remodeling and spotty calcification. So the question lies is, although we order a nuclear stress test and it is negative or non-ischemic, the question lies is, where does a patient stand? Is the patient having non-obstructive coronary artery disease, or does the patient just have no CAD whatsoever? And so that's a question that the CT scan can answer. And going off on this lipid-rich plaque and positive remodeling, and I think it's fascinating, but it turns out that the plaque characteristics that can be identified on CT scan can provide prognosis as well. And so they noted that if you note characteristics such as positive remodeling, which, as you know, is a Glagow phenomenon, where you have positive remodeling index of greater than 1.1, you can see a higher risk feature of what's called a napkin ring sign, where you have coronary artery calcification on the circumference of in the vessel. You can see it in spotty calcification, which are nodular focal calcification less than 3 millimeters, or you can have a more concerning finding, what's called a low attenuation plaque, and defined as less than 30 Hounsfield units. And turns out that in a patient who has low attenuation plaque of greater than 4% of the total plaque volume, they are 5 times more likely to have a fatal or non-fatal MI. And this is followed up on the Scott Hart trial, where where they follow patients with a cutoff of 4%, that they note those with a greater than 4% of a low attenuation plaque burden, they had higher risk of having an event. And although the CT scan can give us and can identify plaque features and characteristics of what's considered to be high-risk plaque, although it's identified and although you can attempt to pursue medical therapy, the question lies in this realm regarding would prophylactic treatment with PCI really help the patient. And honestly, this is up to debate, and there's no answer to it. And I know some radiologists and cardiologists who read CTs don't like to put the vulnerable plaque features into the report itself, since since we don't have an option to treat these patients. And the whole idea of treating high-risk plaque with prophylactic stenting is still under debate. And there's some studies involving OCT, which OCT can identify high-risk plaque. But at this point, we don't have any treatment options other than medical therapy. And the consensus is still out whether prophylactic stenting can help these patients. So going back into the landmark trials, and this is the accuracy trial. This is a prospective blinded multicenter trial, about 230 patients without known CAD. They included patients 18 or older, and these patients had typical atypical chest discomfort. And when they compare CTA versus invasive coronary angiography, they noted that that there was a 64% positive predictive value of 50% or more stenosis, and less robust was that for those with a greater than 70% stenosis, there was a 40% positive predictive value. However, the negative predictive value was very high at 99%, suggesting that when it's a negative finding, it's likely to be negative even on invasive coronary angiography. I just want to touch base on the ROMI-CAT2 trial. This is the primarily ED study in 2012. They had about 1,000 patients of ages of 40 to 74 years of age, and these patients presented to the ED with chest pain or what they call angina equivalent. And what they noted that in these patients, they compared either CT scan, coronary CT angio versus standard of care. And what they noted is that CT scan led to more downstream testing, and in particular, invasive coronary procedure. There was no change in cost. There was a higher cumulative radiation exposure to CT scan. Although they did boast that there was a shorter length of stay in the ED, they were able to discharge patients and with an average of 7.6 hours earlier than standard of care. But overall, in follow-up of 28 days, which is short, but after 28 days, there was no significant difference in MACE. And this is an earlier trial that really set the stage about the use of CT scans in the emergency department scenario, which then led to the PROMISE trial, which came out in 2015. And in this trial, it was much larger, of 10,000 symptomatic low to intermediate risk patients, of which 40% were actually in the low risk range. And these patients underwent either a CT scan or functional testing. The exercise EKG was at 10% of patients underwent an exercise EKG. Stress echo was about 28%, and the remainder underwent under nuclear stress test. And what they noted is that after follow-up of 25 months, there was no change in primary event in all categories of death, non-fatal MI, hospitalizations, or any procedural complications. But they did note that CTA led to reduction in invasive catheterization. So it wasn't really a win in terms of this PROMISE trial, but it did show that a CT scan was, I guess, no different in terms of outcome when compared to standard of care. In contrast, there's the Scott Hart trial, which hence the name was based in Scotland, and these patients, there was about 4,000 patients who were between the ages of 18 to 75 years of age. And these patients were similar population as the PROMISE trial of low to intermediate risk who had chest discomfort. And these patients underwent standard care plus cardiac CT versus standard care alone. And it was a follow-up about almost 5 years. And what they noted was that in terms of what they noted was that after 5 years of follow-up, they started noticing a statistical difference in terms of outcome. And they noted that there was a reduction in MI in those who underwent CT scan. And it's felt at that time, since we just demonstrated and discussed about the CT scan's ability to identify non-obstructive coronary disease, that these findings led to the increase in use of preventive therapies such as aspirin and statin therapy. And there's also an increase in the use of anti-angiogenic therapies as well. The event rate was relatively low, but overall, after 5 years, you're able to see a statistically significant difference. So this was a win for CT. And you may have seen this. You may have seen this trial. It was actually published about a month ago in New England Journal. It was the discharge trial was a European trial of 16 countries. It was a follow-up of greater than 3.5 years. And it was randomized to either undergo CT versus invasive coronary angiography. And they looked at a slightly higher risk group of just intermediate risk patients. And what they noted is that the MACE, there was a pretty similar rate of MACE after 3.5 years. And you notice that there was a cumulative increase that was higher in the invasive coronary angiography group versus CT. However, it did not reach statistical significance. And the question I had was, since the CT scan was able to identify non-obstructive coronary disease at 1 to 4.9%, and it was higher in the CT group versus the invasive coronary angiography, was this finding and the increase in statin therapy use, if this played a role into the reduced cumulative events over time? In terms of meta-analysis, they looked at over 28,000 patients, and they compared all the other testing modalities versus invasive coronary angiography. And what they noted is that the sensitivity for CTA was very high, 97%, and when compared to the other imaging or stress testing modalities. And on the flip side, on this, in terms of specificity, it's much lower, and it was actually less than stress echo or PET or stress CMR. And in terms of functional significant CAD as opposed to anatomical, but in functional CAD, the sensitivity was about 93%, and in terms of specificity, it was very low at 53%. So this goes to show that CT scan was better in ruling out coronary disease rather than ruling in. And this is one of the examples where there's a highly calcific lesion involving the LAD, the mid-LAD, and with the high calcific burden, it actually reduces the ability to identify and evaluate the lumen diameter, and also because of calcium, it causes a blooming artifact. And this is read as significant stenosis, and when invasive coronary angiography is performed, there was no luminal loss. So it just shows that CT scan can tend to overcall stenosis. When we compare it to invasive FFR, you notice that the sensitivity is yet quite high when compared to other testing modalities. However, the specificity in terms of the gold standard invasive FFR was much less. So CT scan, good in ruling out disease, but not good in ruling in. So how is reflected on the chest pain or on the guidelines? So the Europeans were ahead of the game. In 2016, they considered coronary CT angiography as the first line test to be used for those with typical and atypical angina. And for those who had non-anginal chest pain and who had abnormal EKG, the coronary CT angiography can be pursued. This is followed up with the 2019 ESC guidelines, where it was a class 1 indication to use either modality. It was given a balanced recommendation. However, they weighed more on the use of cardiac CT if you feel that the patient has a lower range of clinical likelihood of CAD, or if they do not have any previous history of CAD, which goes to show that the sensitivity was so high in with this modality. So how is it reflected in the 2021 chest pain guidelines? So in the intermediate and intermediate high risk patients who have chest pain and no known CAD who are negative for ACS, CTA was considered to be a class 1A indication. And you can consider use of CTA for those who have a history of mildly abnormal stress tests of less than a year, or if they had an inconclusive stress test as well. It was considered to be a class 2A recommendation for those who had acute chest pain with known non-obstructive CAD, since CTA can be used to determine progression of disease. It was a class 2A recommendation. And one of the I guess, additions in terms of the cardiac CT was that you can use it in patients who had prior CABG without ACS. And the thought was that bypass grafts were less mobile when compared to the native coronary arteries, and the bypass graft has a larger lumen and vessel size. So there's a felt that cardiac CT may actually give better value and identification of any stenosis in these vessels. One thing I do want to note is that in the guidelines, they have this chart where they say favors use of CTA versus favor use of stress imaging. And one thing to note is they use 65 as a cutoff, and they don't really specify how they came up with the age of 65. I think age of 65 is relative, since what we mentioned based on the MESA study, they noted that those with a coronary artery count, those who were between the age of 65 to 74 years of age in females had a coronary artery calcium score of 0, meaning that these patients who may have lipid-rich plaque or no disease whatsoever, they would benefit from a cardiac CT. And even in males, it was about 50% of males who were between the age of 65 to 74 years of age had a calcium score of 0 to 100. And there is newer thought that even with dense coronary artery calcification, that you can still identify stenosis at a relatively high accuracy, especially with newer CT technology. But I have to say, keep in mind that the MESA score did not have those who are diabetic, so that might play a role in your decision making in terms of the imaging and stress modality. So as a case, I have a 41-year-old gentleman, history of hypertension, hyperlipidemia, had an ablation. He was diagnosed with what's called probable non-cardiac chest pain. Just to follow up on the 2021 chest pain guidelines recommendations. He had chest pain for about a year. It was left side sharp in quality, 4 out of 10. He was treated with pericarditis post-ablation, and he had elevated cholesterol levels, total cholesterol of 294, LDL 188. He was checked for other risk factors, including Lp(a), apolipoprotein B. He had echoes, normal, cardiac MRI, normal. He had a stress echo, which revealed hyperdynamic LV cavity with no wall motion, no anterior exercise. He achieved 13 METs, and with a Duke treadmill score of +11, who was low risk. And as you know, those who achieve greater than 10 METs on stress tests they're considered to be a very low risk candidate. He was initiated on metoprolol and amlodipine. He was still having ongoing chest pain. So what's next? So cardiac CT was ordered. He had a calcium score of 206. Majority was in the LAD, and using his demographic, he fulfilled the 90th percentile based on the MESA score. In terms of coronary arteries, he had several tandem lesions, proximate and distal LAD, 30 to 50% luminal narrowing, and the largest plaque was present in the proximal LAD. So what's the next step? Should we consider a SPECT MPI, cardiac PET, go straight to invasive core angiography? Given that these findings, given these non-obstructive disease findings, are these lesions hemodynamically significant, or can we consider the use of CT-FFR? So CT-FFR is a balance between both anatomy and physiology. The benefits of CT-FFR is that after a CT scan is obtained, you can use that data and send it to a company in Redwood City, and who will then process it. Patient does not need to go through any other downstream testing, and no other radiation exposure is needed. And one of the disadvantages of the use of CT-FFR is that there's only one company that's FDA approved to perform this testing modality, and it requires a supercomputer since it relies on really heavy mathematical principles and hierarchical Bayes modeling. So our workstations do not have enough computing power to process these, and it can take up to a week for the results. And earlier trials shows like up to a 13% rejection rate, but currently it's about 3% given the improvement of CT scans, which we discussed earlier. And the Medicare national payout is about $930. So CT-FFR, it's similar to invasive FFR, where not hemodynamically significant is greater than 0.8. Between 0.8 to 0.75 is considered to be borderline, and 0.75 and below is considered to be hemodynamically significant. So one of the early landmark trials regarding CT-FFR was the Discover Flow trial. They looked at about 100 patients who were suspected or known CAD, greater than 18 years of age, and they looked at coronary arteries greater than 2 millimeters. And the CT-FFR cutoff, which you just mentioned before, was that they looked at those who had a value less than 0.80. And what they noted was that when they compare the FFR CT versus cardiac CT angio, just the anatomical assessment, they noted that the positive predictive value was much higher for FFR CT when compared to CTA, and even there's an improvement in terms of negative predictive value as well. And even this is also seen on a per patient basis, where the use of FFR CT improved the accuracy of the study. The CT-FFR reduced false positive findings by 70%. And they noted that the use of FFR CT was superior and added to the CTA evaluation. One of the big registries was the Advanced Registry, about 5,000 patients, and it was a prospective study of 38 sites, and it was an international study as well. And they noted that for those who underwent FFR CT, about 25% of cases were actually deferred in terms of revascularization. And what they noted that the FFR CT of a value less than 0.80, then higher MACE, and there was a higher MACE even higher for those with a 0.76. And those who had a FFR CT less than 0.80, they had more interventions. And this study was actually just a 90-day follow-up, but even after 1 year, they noted that those who had a lower FFR CT value had higher event rates. And granted that the 55 events were noted, which is very small in comparison to the 4,700 patients. The reason why, originally those 5,000 patients, but 300 actually dropped off due to loss of follow-up. But when you compare the 55 patients who had events to the 4,700, it is small, but they noticed that those who had a lower FFR CT value, they had higher risk of having an event. So in terms of meta-analysis, it was 16 studies from 2011 to 2019, and they compared cardiac CTA with FFR CT versus invasive FFR. And they noted that the FFR CT had a higher specificity when 0.71 versus the cardiac CT. And they noted that there was a higher specificity of FFR CT to overcome the CTA's tendency to overwrite stenosis, which we mentioned before. And if you look at the slide, when comparing the sensitivity versus specificity, where the blue line is, that you notice that the blue line represents FFR CT, which goes to show that you can benefit in terms of having more of a diagnostic value within the study. So how was it related to 2021 chest pain guidelines? So the guidelines say that FFR CT can be an add-on test, especially for those with intermediate patients with and without CAD who are having chest pain, and if they had CAD of 40 to 90% in a proximal to mid coronary segment, and they consider to be a class 2A recommendation. So going back to the 41-year-old gentleman, he underwent a CT-FFR He had normal values involving the left main, circ, and OM. The RCA was unable to be interpreted due to motion artifact. And however, when the CT FFR was calculated in the proximal segment, and then he went on to invasive core angiography, and the IFR was performed, not FFR, but IFR was performed and was found to be 0.79. Therefore, he underwent a drug-eluting stent within the prox LAD. And post-operatively, post-procedurally, his symptoms have completely resolved. So in conclusion, there's been an increased adoption of cardiac CT. It's originally started in 1975 and has progressed. The technology has progressed over these years. And even with the slow implementation of coronary artery calcium score by Dr. Agassiz in 1988, and was slowly able to be adopted, the cardiac CT is finally picking up speed in its clinical use. Coronary artery calcium score, it individualizes risk stratification outside of the pooled cohort equation. With the use of coronary artery calcium score, it improves lifestyle and medication adherence. Just please note that coronary artery calcium score of 0 does not exclude CAD in high-risk patients. However, calcium score testing in itself for low-risk patients can be considered given the high negative predictive value. Cardiac CT angio anatomically has high sensitivity. However, this study itself, the specificity is not as robust. FFR CT provides a combined anatomical functional evaluation. It can allow providers to defer invasive core angiography, and it can help even further risk stratify patients. So there has been a continued advancement of coronary CT angio. There's now a dual source CT, which allows the radiologists and cardiologists to able to further identify the calcium and can identify stenosis within the calcific lesion better. And in terms of CT, the current CT slice thickness is 0.5 millimeters. However, there are now newer CT scan with ultra high resolution that has spatial resolution of 0.25. And when we compare that to invasive core angiography, the spatial resolution is 0.16. So the cardiac or CT scans are getting close to the same spatial resolution of a cath, although the temporal resolution still has ways to go. And with the use of an ultra high resolution CT scan, and this example above, where you notice that with ultra high resolution CT, you're able to see through the calcific stenosis, since given the smaller slice thickness having less voxel size, you can get a better identification. You can actually see in those with stents where with a smaller slice thickness, you can better identify for any stenosis with an ISR, and also you can better see vessels. And I just want to thank my editors. They were listening to my lecture yesterday, and they gave some feedback. Does anyone have any questions?
That was terrific, Jeff. Thanks for that extremely enlightening and thorough review of a complex subject. I have a couple of quick questions, and of course, we'll open it up to the whole audience. One is, this is such a technically advanced area that most of us don't really have the background to really understand all the depth of engineering and physics that goes into all this. One just simple question is, when I order a coronary CT or a CT CAC score, calcium score, my patients go to different centers for this. Some end up at Cooper, some end up at other health systems, some end up at private radiology. I would imagine every scanner is different and the readers are different. So how does inter-observer or inter-center reliability, how do we account for that? I mean, should we trust every center the same? Can you talk about quality issues, and how do we assure that the quality is there?
That's a great question. So you're right about that. There can be some inter-observer variability in terms of reading. I do know that I think the Society of Cardiology CT published data on like last year, stating that those who are considered to be level 2 readers versus level 3, they noted that those who are expert readers of level 3, who've been reading over 1,000 CTs, actually had a more accurate diagnosis. In terms of, I guess, comparing between level 2 versus level 3 readers, actually, I do not know if there's been a study to really look into that. But there is definitely a difference between the experience.
Understood. And one other question is, in terms of follow-up of these things, let's say I get a coronary calcium score or even a CCTA. How long is that valid for, particularly a calcium score? I mean, is that 5 years, 10 years, 1 year? What are the recommendations to repeat it?
Yes.
Let's say you did it at maybe at age 40 or even 30.
Yes.
When do you repeat it?
So they actually recommend about 5 years in between coronary artery calcium score. And actually, the National Lipid Association published that those who had a calcium score of 1 to 99, you may repeat a coronary artery calcium score, and I believe it was in 3 to 5 years. But those with a calcium score greater than 100, they advise that you may defer any further calcium score, especially with statin use, which I know you've mentioned before, that statin use will increase the coronary artery calcification due to the remodeling and the healing process.
Yeah, exactly. That's kind of why I was bringing it up, because we have all of our patients that have low scores. We put them on statins to reduce their risk, and of course that increases the calcification, so it's going to be confusing. Anyway, this is a fantastic area. Let me stop and give others a chance to ask questions. Anybody have a question for Dr. Lee? Feel free to speak up. I don't hear anything. So I have a question. If you wanted that FFR, is that something that an individual practitioner can refer to the California company, or how does that happen?
So technically, there has to be an agreement between the university or company with the it's actually called HeartFlow, and then after the agreement is made, then you can contact the company and they can then analyze the CT data.
Okay, I see.
Jeff, this is Vivek Kulkarni. Can you hear me?
Yeah, I can hear you.
Hey, sorry, we had some audio difficulties a second ago. I have a question about outpatient use of CTA. My understanding is that in order to do a CTA, you need nurses, you need metoprolol, you need nitroglycerin. I mean, are there any outpatient level facilities where it's feasible to do a CTA? My understanding is no, and that if we do it here at Cooper in our system, it has to be done, in the hospital CT scanner. But I just wanted to see if I'm wrong about that.
Oh, so actually, I just spoke with, I think South Jersey Radiology was one of the private radiology groups in the area. They actually have nurses to administer oral metoprolol. I will say, though, that for a patient I recently sent, they actually omitted nitroglycerin for whatever reason. And you're right that nitroglycerin should be used because that actually improves the diagnostic accuracy. So I guess it depends on the facility, but I know for sure South Jersey Radiology can do them.
And then the other question I had is about, I'm sorry, I had to come in a little late because I'm on consult, so I'm sorry if you already talked about this, but it was about heart rate optimization for CTA. I know that it depends, obviously bradycardia is better, but it depends on the scanner technology. I was just curious about, the scanners that we use here, and I know some of the newer scanners can scan at higher heart rates, and it depends on if you're gating retroactively or prospectively. And I just was hoping you would talk more about that if you haven't already.
Yeah, sure. So you're right. So lower heart rate improve the image quality, and you are right that for those who have a higher heart rate of 65 and above, you can use retrospective gating, which essentially is just turning on the the CT scan throughout the entire phase, and afterwards, then you can edit it and look through the diastolic phases. As for the R scanner, we have like a 320 slice, I think Toshiba, and technically, even with a 320 slice CT, this is enough coverage area to even do like a flash CT, which you can just turn on briefly with one rotation. So you are right that that certain certain facilities have different ways of overcoming the heart rate.
Okay. Yeah, I really appreciate your talk, as I'm a big believer in coronary CTA, and I think we should use it more.
Awesome, thank you.
Any other last questions before we close? All right, well, it's a little after 1. I again want to thank you, Jeff. This was really enlightening. You covered a broad array of topics within CT, and there's a lot to learn, a lot to know. We thank you for your expertise. I want to remind everybody it's a CME program. Please fill out your reviews and send them back to Tina Moorfield. I wish everybody a happy holiday. And I look forward to next month. We're going to have an outside speaker come talk about hypertrophic cardiomyopathy. So we'll look forward to that as well. Take care, everybody. Have a great day.
All right, thank you.